Welcome, everybody. My name is Maud Brahmi, Division Manager here with the Fresno County Department of Behavioral Health. This is our BHSA, which is the Behavioral Services Act Integrated Plan um, report back session. So, one of the things that just might be for those of you guys that might be new or maybe have forgotten in the past, Fresno does something a little different where we've always done what we call a report back session. It's a way for us to kind of recap what has been done as through our community planning process in developing what used to be the MHSA plan, now the BHSA plan. Kind of giving you guys some summaries of what's in there and just some timelines as people are utilizing the time for the review of the plan and providing public comment and feedback. One of the reasons we also wanted to make sure that we did this report back session was with all the changes from MHSA, the Mental Health Services Act, to the Behavioral Services Act. We want to give people some of the understanding of the changes. So if they went and looked at the plan and why does the plan look different, why there might be some different components or aspects to it, to be able to just provide some context for that. So this is our report back session. We'll spend some time kind of just providing you guys with some updates, letting you know what's going on with the plan, some timelines, things of that sort, and then allow for some questions. We are scheduled for an hour. This should not take the full hour, but we want to make sure we do provide time if there are questions, and we will try to answer those the best we can, either on this session or follow up with people later on. So just real quickly, this is a recap. And we are doing this via live stream right now. However, if you're running into any glitches or issues, don't worry. We are also recording this, and it will be uploaded to our YouTube page so people can go watch it later on, or when it's convenient, or if they want to follow up on a particular area, maybe if they missed something. So that's also just a heads up for you all. So just real quickly, a review of what is the BHSA plan. The BHSA integrated plan came about as a result of the Behavioral Services Act, which 2 years ago in 2024 was known as Prop 1. We tend not to use, my team, the proposition numbers for these acts, because once the propositions pass, the proposal becomes an act, so it becomes something that is in regulation in law. And the state does reutilize or reuse those propositions every few years, the numbers, because they do not have an infinite, well, I guess technically numbers are infinite, but it would become difficult to try to do proposition 57,722. So they tend to use usually a handful of numbers for that. So formerly was Prop 1, but it does, Prop 1 made the Behavioral Services Act the new act. And so it will be replacing the Mental Health Services Act come July 1. BHSA reallocated some of the funding that before MHSA had. So just a reminder that it's not new money. That was kind of a misconception for a while, that, oh, there's more money or new money. It's the same money, and it's kind of reallocated in terms of what are the priorities to be utilized for those. And in some regard, it lowers the allocation that counties get, with it increasing some of the state's allocation. Okay. Brian's just doing some technical stuff while we're still live, but he's so good you don't even know that he's doing that right now. Just a reminder also that we do have with BHSA, there are 3 priority areas, if you guys remember. It was housing, which requires half of those housing funds to be utilized towards addressing individuals who are chronically homeless and with a behavioral health condition. So that's just something we wanted to remind. 35% of the funds go to full service partnerships. That's now the broader category. Before, full service partnerships were type of level of care or type of service in our level of care. Now all of the more high intensity, higher acuity services are under that FSP umbrella. And then 35% of the funds fall into what is being called the Behavioral Services and Support Act. Big thing to remember in there is half of those funds must go to early intervention. And of those half of that funds must be utilized for children and youth. So to kind of break it down, it's really trying to balance out and make sure that there are efforts targeting specific populations, including youth, older adults, unhoused individuals, to really try to address early intervention and first onset to reduce some of those challenges for individuals and families in the future. The BHSA integrated plan, that IP part of the integrated plan is going to replace the MHSA 3-year plan. The reason it's the integrated plan, it's going to go from where the MHSA plan, if you remember, focused on how you were going to use MHSA allocated dollars for service and programming. The BHSA integrated plan is an overall plan for our entire system of care. So it's not limited to how BHSA funds are used, but what is the plan for your system of care? And so that's where that integrated term comes from, because it is an overall encompassing plan. And it really strives to try to incorporate and integrate SUD and mental health into truly one behavioral health, so they're not as siloed and fragmented as we've had historically. System-wide plan, like I said. So how is this different than the MHSA 3-year plan? Like I said, there's the variations that it is encompassing of all our services, not just those that are funded by mental health. It does change a little bit from the past. The budget is really set up differently than we did. It's their budget templates, or the budgets that we include in the BHSA plan, is for all the counties' behavioral service dollars, not just those that are coming out of BHSA. So it's opioid settlement funds, 91 and 2011 realignment. Counties that get general fund utilize those. We're not one, but there are a few counties that get some general funds. If counties have grants like federal or SAMHSA grants, or other kind of grants, those are included in there. So it encompasses everything in there. The state has created the template for the integrated plan, and the way the plan is now developed is there is a portal, and counties log into it, and then we answer the questions and fill in the information in the portal. So it's very kind of structured how it does it. Before, we would write, and as a result, each county would write kind of their style, their flow, how they structure things. And so for a lot of times, for policymakers, auditors, things like that, it was a challenge, because everybody may write their plan different. They may put things in different places. They may have different interpretations. So part of what this 3-year plan is very structured. There's specific areas and sections and questions we answer. We have like word counts or character counts in terms of what you put in there. They have templates for everything that's used for like the budgets. The information and data that we put in there are specific data sets we have to use and respond in certain ways. So when you read it, if you read it, it is a little more structured and flowing in the way it does, and it will appear differently than if you've reviewed our past plans and annual updates. But if you go online and look at other counties, their BHSA plans, the information may be a little different in terms of what's contained in there, but the flow and the order of everything will be the same. So if you're a provider who operates in multiple counties, if you can find something in one plan, it should pretty much correlate and match with other counties in terms of where that information is provided. Let me see, what else can we touch on for you guys? Like I said, the layout is a little different. So it does go in a portal. We do convert it to a PDF, and then that's what's posted, so it becomes easier for people to review. Like I said, it will provide a more overview of the county. It does have some specific sections, the statewide behavioral goals, as they call it. Those are areas where we had to provide, we're provided with population level data, and then we have to utilize those to address gaps, disparities, things of that sort. And the data set comes from the state. At this time, it is going to be driven by the state. Data in the future, we will utilize more of our specific data over the years to come as those programs and a plan progresses and we have more information available. There's a section on community planning process. So some of you were involved with that. The community planning process was a lot different than you had experienced in the past if you had done it in Fresno. If you all remember, we had a very robust community planning process to where we would do maybe 20 in-person forums, nights, weekends, days, rural communities, clinics, drop-in centers, etc. With this one, we still had to do a robust process. We did have an extremely shorter time to do it in, because as the guidelines came out closer to when the plans were due, it did allow us less time. We historically would start these processes in the fall, be able to have time to process through those and write these up in the spring and submit it by the summer. We had to have the plan submitted by March 30th, so it did change up some more timeline, and we did not have details until later in the year, which made it kind of harder for us to go out and do forums when we weren't sure what all we were needing to cover. The community planning process is a lot more prescriptive now, so there are specific stakeholders that they want us to engage, but in Fresno, we'd already been doing that, so there was really no change for us. But we did not have as many forums. We did have some in person. We had some virtual. We did provide surveys and other ways for people to provide input. Where different is because it is a lot more prescriptive and not just a community planning process, but the services we have to offer and are required to be provided. We needed to make sure those things were addressed. And when those things are addressed and are we able to cover those, it doesn't have a whole lot of room for a lot of new or kind of creative ideas for programs. And so we did have those stakeholder process, but because they were so structured, we did not want to have an excess of them where people are taking time out to come to it and that we really wouldn't be able to utilize a lot of their input. So what we did with these is more of kind of present what the changes were, what the new requirements were, and some of how we were going to fulfill them. And we took input where possible from folks, but if you had been involved with our community planning process in the past, we literally would have blank flip charts, and we would start asking you guys, what are the needs, what are things that you guys see could benefit folks, and we would start from there. Like I said, this whole process is a lot more prescriptive because there's a lot of mandated services and programming that is expected because they hope those programs and services will help address some of the behavioral challenges we're facing around the state. So that was just some of the things with the community planning process. The community planning process, I mean, technically is an ongoing process. So for us, like at this time when we're taking public comment, we will have the public comment session in the future. But our goal has always been and will continue to be that throughout the year, we will try to have focus groups. We will try to have community forums, town halls, wherever we can engage with the community to get ongoing input. And I think now that we have a better sense of what the BHSA plan is going to be like, now that we've got the final policy manuals and know all the categories, we're able to do a lot more work in terms of how do we refine and improve those services and outcomes and really make sure that we are addressing our community needs with those services. There is a whole section in there that does have Behavioral Service Act funds and programs. So it's specifically what are we utilizing those BHSA dollars for. So like I said before, the MHSA plan was how you were using MHSA dollars, and that was it. This plan is overall all the services that we do in the county, but they also want us specifically to still know what BHSA was going to be funding. And the programs were broken down into areas of children's system of care, adult system, early intervention type programs, FSP level programs, housing and housing interventions. So if you go through the plan, you'll see some brief descriptions on those. We did not get super detailed in it, again, because there's a certain level in terms of character counts that you can have. So we did try to provide enough details in there so that anyone new coming to it would get a good picture of what the service and program is doing in its intent. But we didn't get into like all of the nuances that we could potentially do with a program description. We do have to address workforce strategy in our plan. Before we would have a WET section, but that was tied to the WET funding under MHSA. Under BHSA, you can, if you have dollars in your BHSA plan, use them for workforce, but it's not a separate set aside. However, we are required to have a workforce strategy. And so if you review that section, it talks a little bit about what are some of the things that we're going to try to leverage and address to improve workforce recruitment, retention, just to make sure that we're able to address the capacity needs to be able to implement a lot of the services that are mandated. You do need the personnel and the professionals to support those. So that's where they kind of align. Budget and prudent reserve section. There's a whole detailed accounting section on that in the plan if you want to go look at it. There's a slight change in MHSA from BHSA. And MHSA prudent reserve was assessed every 5 years. Now it's assessed every 3 years for large counties. The amount that is set aside is reduced. They want more money to go into the direct service, and so the rainy day fund is reduced. Hopefully, we don't have to tap into those ever, but there is less in that rainy day. Something that might be of interest in a report out session, if you're tuning in, is what are some of the programmatic changes? What are some changes in the BHSA? Well, there's a couple of things that are new to BHSA. Like we said, there's a specific housing component. So anything that we were doing before with housing, including housing that was tied to maybe some of the FSP programs, housing that was tied to some of those other things are now in the housing bucket. Housing funds do have some very specific uses, so they do clearly identify like how you can use those funds. Housing funds are supposed to focus on things like rent, deposits, some of those things. There are some capital opportunities with housing, but supportive things related to housing are not part of the housing fund. So those are just some things that are a little different. So when you read the description, look at the housing, that's how it's set up, and that's why they're identified a little differently. Uh, some of the things that we're looking at is some targeted housing outreach. Obviously, one of the things that you see in the BHSA plan and in the policy manual was to target encampments, target individuals that have been chronically homeless. So really looking at some efforts in those areas. Some of the things that are new is that there are specific evidence-based practices that are now being called out that counties are expected and required to implement. So those are ACT, which is assertive community-based treatment, or FACT, which is forensic assertive community-based treatment. It's a either or. You can have an ACT or FACT. In Fresno, we will have an ACT and the FACT. Those are the highest level of care that you have outside of an inpatient setting. The full service partnerships that California adopted some 20-something years ago as part of MHSA were like an ACT, like that was the model that they worked off of, but there was some tweaks to it, so it wasn't exactly ACT or FACT. Now we're required to provide ACT or FACT to Fidelity, which I'll get to the Fidelity in a second. There are individual personal supports, a program we already have that's existing, but now that model is required, and it's going to be something that has to reach Fidelity. One of the newer ones is high fidelity wrap is a new requirement. So for children and youth, where we would have FSPs in the past, the full service partnerships, we now will have high fidelity wrap. So the high fidelity wrap is for that level of care, but it is and we can go into all day on explaining the high fidelity wrap model, but the high fidelity wrap team will coordinate care, and there will also be a separate treatment component. We've had a lot of delays, and there hasn't been a lot of details provided in that because we got the high fidelity wrap guidelines and some of the information on what that's going to look just last week. So all 58 counties and cities have been waiting for that information. So some of them have kind of guessed what it was going to look like, and we'll now go back and revise. We're still in the process of developing those to make sure that we have those available and up and running. But like I said, we literally received those information last week, and we submitted our draft BHSA plan, which is on our website if you've looked at it, on March 27th. So about almost a month after plans were due is when the information came out. So we're still playing a little catch up, but all counties are, and I think the state is aware and kind of understanding that we may have to make some changes to those. One of the other things that is a requirement now is coordinated specialty care for first episode psychosis. So this is an evidence-based practice to really help with the first early onset of psychosis or severe mental illness. It goes into our early intervention. So it's called out in our early intervention that you must have this as one of your programs and work towards Fidelity. So we've had a lighter version of this over the years trying to do so. This will really help us strengthen and have a formal CSC for FEP that meets Fidelity, which will really improve and enhance outcomes for folks. So that's another new iteration that you're seeing in this plan. As I mentioned a couple of times, these evidence-based practices are not just like you have to do them, but you have to do them and meet Fidelity. They do give us some time, so the Fidelity has to be met by the end of fiscal year 28-29. So by June 30th, 2029, all these programs do have to meet Fidelity. The state has connected counties to a third party that they're contracting with to provide the technical assistance as well as the training and the Fidelity check. So it'll be a neutral third party that will vet the counties are doing the Fidelity checks. This is really important because meeting Fidelity is what's going to make those programs effective. So that is something that we are wanting to do. And also you have to meet Fidelity in order to be able to render those programs, to claim Medi-Cal, to get funding for them. So there's an incentive for all counties to make sure they get this done and their community partners and get it done in the time allotted so that we can make sure that we're not going to be experiencing adverse consequences of not getting those done. The BHSS pot, less focus on that, but half of that is the one, like I said, that goes to early intervention, and half of that goes to youth. One of the things we said was called out in there is that coordinated specialty care for first episode psychosis. So that's going to be something that will be coming out of that particular pot. One of the things that's required in there. There are some additional evidence-based requirements or practices that counties are required to do. They're not required under the Behavioral Services Act, but they are required now for counties to do. And so overall, the county through BHSA, as well as some of those other requirements, is going to be lifting up a number of new, couple of existing, but a number of new evidence-based practices. And hopefully those evidence-based practices will help us and our community receive better outcomes, better care. So the other three that I was mentioning are PCIT, parent-child interactive therapy, family functional therapy, which is ideal for working with individuals who may be experiencing some brushes with justice involvement or with child welfare. Really, it's a full family focus to support in that. And then multi-systemic therapy, MST, is another one, evidence-based, that we'll be working on as well. Um, kind of touched on some fidelity checks. What are some of the things we can hit you guys up? Oh, one of the other things that's new is a requirement. It's not a program, but it's an initiative under the Behavioral Services Act, which is assertive field-based initiation for substance use disorder. So this goes to that integration part we were talking about. Really emphasis by the state to make sure that under BHSA, we don't continue to have these silos and fragments of mental health and substance use. How do we really support those? And so part of it is to really be in the field and engage individuals that maybe have a substance use only or a co-occurring, to engage in services. So part of that is to help improve integration. Some of this work is going to be, outreach. Some of it is going to be same-day access. Some of it is around medication assisted treatment. So there's a lot of options that counties have under assertive field-based, and so that's something that we're doing. You did not have to set up a standalone or a brand new program. You could leverage existing programs. If you already had a program that's doing that kind of outreach, you could just utilize that. But they did want that in a plan. They want to really make sure that it's addressed and identified to make sure we're doing those. So your housing outreach coordinators could do some of those things. So there's a lot of options in there. Some of the things that people can do and that we've looked at is how to utilize, for example, some of those opioid settlement funds to support things like a mobile map program, supporting some additional specific trained substance use specialists and folks with that addiction expertise to support some of the housing outreach, working with encampments, reaching out to people that are unhoused to help with screening, assessment, get them into MAT, get them into detox, get them into treatment. So, and then there's some hopes for us in the future to be able to add some additional MAT and substance abuse services to improve same-day access at some additional clinic sites, things like that, to just make it easier for people to get services. So that, like I said, a lot of effort in this structure, the way the state is done to try to integrate services. Programs that were funded by MHSA but are not going to be funded by MHSA but are still continuing, because that was a question we've had at times, like, well, how's that going to work? So there are some programs that were funded previously by MHSA, but will not be by BHSA, but we're doing, and a lot of those are our internal outpatient services and a number of fee-for-service outpatient services. So what we've done is at times we were using MHSA at that point either to fund some parts or components of those programs or utilize some match or some of those things, and being that we're not utilizing BHSA because they're not reaching that level of care, or the outpatient or the low levels of care, we will continue to provide those services. We are just restructuring some of those programs, doing some redesigns with them, and working on ways that we can leverage Medi-Cal claiming and things of that sort to continue to support those services. So there won't be a reduction in those treatment services. We just have to adjust how we are funding those and maybe some of the structuring to make sure we can support those properly. There were programs that were funded by MHSA, but were sunsetting with a transition to BHSA. Some of you already heard these when we talked about these in the community planning process, but a lot of that had to do with things around prevention programs, with the exception of substance use prevention, because it's a whole separate thing. But a lot of our prevention programs, things like suicide prevention, a lot of the work around stigma reduction, some of our general outreach, community education, those things are programs, and those kind of work are sunsetting because they're no longer covered under BHSA. They're things that the state is taking over and assuming, and so they will be driving suicide prevention efforts, statewide stigma reduction, things of that sort. The outreach that will remain, that you will see us involved with, are going to be tied to a number of different efforts and programs that are really going to be forward targeted. So they're not going to be informational outreach, but they're going to be targeted to street outreach and hospitals and things of that sort to working with people that have a serious mental illness, that have a serious substance use, co-occurring things of that sort, that are going to be would be eligible and need these higher levels of care, making sure we're navigating and helping them get those services. So there'll be outreach, but it's going to be a lot more targeted with the goal of getting people into the right level of care, getting them into care quicker, faster, more seamless, and improving outcomes. So the county will still do outreach events. You'll still see them doing some of those, but not in the level that we had previously, where we were doing a lot of that to focus on things like suicide prevention, stigma reduction, community education. The focus now, or the large part of our outreach, is going to be really to target those folks who need to be in service and programs and they're not yet, so we can get them in. Let me see anything else that we could touch on those ones. There are some changes still in progress. So we're working on standing up some internal FSP ICM. So FSP ICM's intensive case management is really not the best name, because we have full service partnerships, and then under the full service partnerships, things that are not ACT and FACT and are really more along the lines of what our current FSPs are being called ICM intensive case management, but it can be a misnomer, misleading, because it makes it sound like you're just getting case management, and folks are not. It's still that level of FSPs to where you still need to get therapy, you're still getting those case management, you're still getting those supports, you're still needing maybe the psychiatry. So it's all of those dynamics are still involved in it. So what we in Fresno are calling it is FSP ICM, so that FSP name still remains with the ICM, so it doesn't confuse people that it's just case management, but it still might. I mean, we're working with the acronyms that were being provided at this point. But those ones are remaining, and we're actually going to be working to expand those FSP ICMs internally so that we can have more of those high level of care services available for people who meet criteria, who are eligible, to just, again, improve people getting those help that they need quicker, faster, and helping with stabilize. We're aligning some of our children's FSPs with the new high fidelity and wraparound programs with the new high fidelity wraparound, to meet that model, to meet some of the requirements. As we're getting the guidance, we're trying to align and adjust those. So those are some things that are changing. Like I said, those just came out last week, so we're still working on that. And then there are a number of requests for proposals that are out right now that are also in the queue to come out, as either we're needing to add some additional services, as we're amending some services, or as we're needing to maybe, as we just have existing agreements that are coming to and just happen to be in that cycle. So for our community-based partners, there's a lot of opportunities. So make sure you're checking out the purchasing website for those RFP opportunities. I'm going to touch real quickly on something that I think is important for everyone, which is the behavioral health transformation goal. So there is going to be a section in the plan that you'll see on the BHT goals. So I wanted to talk a little bit about those. These are goals that are set by the state to improve the overall wellness of California and Californians. There are 12 of them. Counties are required to use 6 of them seven, but there's 6 that are prescribed, and the 7th one counties can pick on their own to try to use to help assess and measure how effective our programs and services are. So the 7 goals have some specific data that we have to use. You have to utilize that data to kind of assess and measure your service and program. In the first round, of what you see in the plan, the data is more general population that the state provided. In each subsequent year, they want us to utilize the more specific local program and individual served data. That just was not available for all the new things that were being required. So they did give us some general statewide and county level data. These are going to be used to assess programs and services, how effective they are, identify and address disparities, helping improve outcome. It does provide the state and us some oversight, but it also helps our overall system of care to become more data informed. And just one of the things that is important too is the managed care plans are also having to address several of these BHT goals, because it is system wide. It's not limited to just public behavioral, but they measure those BHT goals for the county as a whole. So they're also focused on some, and there's I think for all 3 of our MCPs, the 3 goals they have are also the same ones we have. So there'll be a lot of opportunities for us to coordinate, collaborate, and look at how we can improve outcomes. So that's really something that excited about that we'll be able to work with our managed care plans on. Real quickly, I'm not going to go through all 12 goals, the BHT goals. You can look them up. But the 6 goals that we are having to do, that every county is having to do, relate with increasing access to care, working to try to reduce homelessness, working to reduce institutionalization. And by the institutionalization, they mean like hospitalization, long term hospitalization, state hospital, things like that. Reducing justice involvement, reducing the removal of children from homes, and reducing untreated behavioral health conditions. Some of you may say, well, like, aren't there more people that should be involved in that? Yes, then the state has acknowledged that. They're starting with the behavioral health side on these, and in time, they plan on getting other sectors involved in these goals as well. But right now, it's us and the managed care plans and folks that are on the behavioral health side. For the 7th goal, we had to, again, utilize specific sets of data, and we brought those out to our community planning process to talk to folks as far as what we were thinking and selecting based on the data. And so our 7th goal is working on helping individuals with that are being served by our behavioral system engage in work. We already have really high unemployment rates in our region and in our county, and there's a disparity for individuals that have a mental health or substance use. And so it's those that are able to try to get them connected and to start some of those processes as well. So that's the goal we did, because it was one that we have a overall lower performance rating, and there's opportunity to improve those. The state also had some of these goals. If you were performing high, they didn't want you to use those. They wanted you to focus on areas that you could bring up scores. So Fresno's done some great work across the past 7-8 years, working across sectors with so many partners to address suicides. And because while our rates are still too high and we still are working on those, we have seen trends go down. We've seen more people reaching out for help. And because of the data that was available, it was almost like, Fresno, you're doing good in this area, so focus on another one. And I think for a lot of us that we're doing suicide prevention work, it's like, well, until it gets to zero, we don't want to stop. But it's not that we're stopping, but where we're going to be focusing some of the measures is going to be in that particular area. I'm going to wrap up after this, just the timelines, because I think after that, that'll still leave us some time for questions if there are one. But I think some timelines that are really important for people to be aware of. All counties were required to submit their draft BHSA IP integrated plan to the state by March 30th. Some submitted earlier. A lot of folks got into March, and a lot more of us were in that tight timeline. So we submitted ours by March 27th. The state has 30 days to review. They don't say approve, but they review your plan and provide you with feedback on things that they want to have revised. The final plan has to be done and approved by the Board of Supervisors by June 30th. So it's really a tight timeline with all the things that are being required. The HCS did do its 30-day review, and they submitted the plan back to us. It was like maybe 12:30, I want to say, on April 20th. And so from there, the clock started, and we have 15 days to address and provide any of the revisions they provided and suggested. There were about 120 revisions, if you want to say that. 49 of those, or 47, I can't remember the exact number. It's 49 or 47. I remember it's a 40 number in the odd upper, so it's now 44, so it's got to be 47 or 49. The logic on that. That's, I remember for some reason that in there. We're specific to like the budget. So now that it was more of like, you didn't use a certain formula, so change the cell. Hey, make sure you have a decimal here. You can't use a decimal. There were things like that. Those are available if people want to look in, but they were really like dealing with the formulas and some of the templates. The rest were things that we have been asked to address, so we are working on those. We're on track to have our revisions done and submitted by May 5th. And when we do submit those to DHCS, we will post all of those revisions back onto the website, and it'll go out if you're on the listserv, so you will get to see exactly what how we responded to those. When we did receive those, we posted our plan on April 7th for everyone to look at. So it was we did submitters on the 27th. We had the weekend. Then we had to have us here to be able to post it, but we did get that up there. So it's been posted since April 7th if you want to go look at it. Late last week, we posted the revisions that the state has asked us to do. Yesterday, on Friday, we got notice from DHCS that they have added 3 more discussion areas, questions related to the CARE Act, or sometimes called CARE Court. So those came in after people had even submitted their revisions and got their plans approved. So it came really late, and DHCS said, it was something that they were tasked to do. So they did push that out. So that one we posted yesterday on the listserv and the website, our BHSA just so that it's BHSA Fresno BHSA. FresnoBHSA.com. Save that, tab it. That's our BHSA page. All the plans, updates, meetings, anything related will always be on there. We posted that yesterday just so people could see what those CARE Act questions were. And then once we provide the responses, we'll also post those on there. That still is also due by May 5th for us. So we're working to get those done. We plan on having a public comment or public hearing, on May 20th at the Behavioral Health Board meeting. We are accepting public comment now. We've been accepting public comment since we posted the plan on April 7th. You can do it by just BHSA at FresnoCountyCA.gov. That information is also on the website, FresnoBHSA.com. You can go on there and get the info. So you can email us questions, comments, things of that sort. We are going to actually have our public comment go all the way up to the public hearing. So there'll be a month and a half, almost 2 months that we will have had opportunity for people to review. And part of that is because as we got the revisions, or like this on Friday when we got that new CARE Act questions that were posted, we're trying to update those as real time as possible. And so allow people to kind of check and see if there's been any changes, things of that sort. We hope that DHCS will provide us, once we submit our feedback, our revisions, it'll be good to go, and we will move forward with trying to have this to the Board of Soups for a June meeting to have it approved before June 30th. So that's kind of our report back session, kind of an overview of everything related to BHSA and the plan. It's not as long as in the past that were 600 pages, but it is still long because of a lot of the supplemental information documentation that's in there. So I am going to check with our team on here and see if there's any specific questions. And if there are and I'm not able to answer them, we definitely can email you back some of that information as well. Thank you, Lisa. She put, for those of you that might be looking in the chat, it is FresnoBHSA.com, as Brian said. You can, like I said, tab that because all of our BHSA things are on there, and that URL makes it just a lot easier for people to find. The MHSA or BHSA, the BHSA email is up in two, right? Right?
What's that?
The BHSA email. I think we have both now.
Yes.
So we previously used to use the MHSA at FresnoCountyCA.gov. You can still use that. If you're sending emails to that, we're getting it. We'll be able to respond. We did update and try to transition to BHSA just so people would not get confused. And we're like, wait, this says MHSA. Is this old? Should I not use it? No, you can still use it. And we've added the BHSA. And hopefully in the next 6 months or so, we'll transition away from all the MHSA stuff and land solidly on the BHSA thing. So, if you have any questions, comments on the social media, let us know. If you're on this one, you can use the kind of like raise hand feature if you're on Teams. If you're watching this later on a recording, write down your question, email it to us. We will add, if it's a feedback or comment, we'll add it to public comment. And if not, we will respond to you as well. I'm trying to see how am I going to.
I don't have any comments in the social.
I have a raised hand. I'm trying to see if I can, if we can unmute them. Oh, you can unmute yourself, Brooke. There you go.
Yeah, I'm on Teams. Was communication to the public across the continuum brought up by the state as part of the document you completed? Since I'm still reading it, I haven't gotten through more than the first third.
I need you to repeat that question.
Yeah, well, Brian needs you to repeat the question just so. Oh, me. I have to repeat the question. Okay. Can you repeat the question for me, Brooke, so I can kind of understand it, and then I can also repeat it so that the audio will capture it?
Yes. Was communication to the public, and this is in chat, was communication to the public across the continuum, the behavioral health continuum, brought up by the state as part of the document you needed to complete?
Let me read that, the questions you put in the chat. Thank you. And I will see if I can answer if I'm understanding the question. So was the communication to the public across the continuum, the behavioral health continuum, brought up by the state as part of the document that we have completed? Are you speaking as far as like the revisions, the timelines? or just the need to have or need to have an integrated plan?
Yes, I view integration
Hmm.
as being um, across the entire continuum, and frankly, with other departments. But I understand that you're not there yet.
Correct, right.
So the integration with across the continuum, the Behavioral Health Board has repeatedly brought up the need for more communication to the public about where to go for different levels of care.
Gotcha.
So now that the managed care plans are responsible for mild to moderate in full, how is that being addressed in this plan?
Gotcha. Um, DHCS has put the completion of these plans and even the BHT measures, the goals, the outcomes, solely on us. We're responsible for our outcomes, yet they have only recently started really pushing that kind of, how should I say? They're now working, the MC managed care plans are also working on the BHT goals. But the way they did this plan is they're moving towards that. So as far as where people will go for levels of care, I think those are still things that need to be developed. However, what they did require for this is for us to work with our local behavioral health departments. All counties are having to do that with involvement with the CHIP and the CHOP, which is the CHIP is what the health, uh, California Health Improvement Plan, and the CHA is the Community Health Assessment, which public health departments do now with the managed care plans. And so now we're all involved together. So we have regular calls where all the partners are at the table and we're starting to have those discussions. And that was a requirement that the state put for these plans, which I think was a way to kind of push us together to start working together and talking. And one of the other things that they've put is that they really want those ECM, that care coordination, to be done to make sure that programs that even if we're serving someone in one of, let's say, the county run or county level programs, to link the person to a managed care provider that's doing ECM, because there's other ECM benefits that they could still benefit that's not, and that they could receive that's not a duplicate. They're also really pushing the coordination around things like transitional rent. So the transitional rent benefit is something new that we would need to connect people with the managed care plans for. And so for the housing, one of the things that they've done to kind of get that cooperation happening is, before we can use BHSA dollars for housing, for like rent, things like that, we have to make sure that the person is not exhausted that transitional rent benefit through the managed care plan. So they're slowly moving in that direction. And I hear what you're saying, Brooke. I don't think it's quite there in this plan or this iteration of it, but I think this plan, what it did do is kind of force sectors that maybe ran parallel and didn't really have that level of interaction to where we're going to be a lot more crossing paths and having to do a lot more collaboration, which will hopefully kind of talk about what you're doing, that we have a more seamless system overall for care. We still have different requirements than, for example, the MCPs. Our timeliness standards are different. Our things that we need to do are a little different. So we're still kind of operating a little separately, but they are getting us more aligned. The state has really utilized the BHSA plan and the whole process to try to get us. They want us to integrate, but until we get there, they at least got us going in the same direction on the same road with us, eventually, hopefully converging eventually. I don't know if that answers your question. I know it's a long answer, but it's a little complex as far as what the state is trying to achieve. There's another question that says, "Are from Brooklyn?" It says, "Are the differences in the measures between MCP and DBH called out in the document?" No, they had the counties just focus on the 6 BHT goals that are required, and then the 7th one that they select. I know the MCPs have like their plan that they also have to do for the state around those goals, and so that we've had some conversations in terms of what are which ones did they select or have to do, which ones we're doing, and they are around the access. Housing and homelessness, and I want to say there was like one with justice involved. So um, we've had conversations. It's just part of our planning and kind of the community plan process. But the plan, our BHSA plan, is very specific in what you put in each part. And so they made no reference or have not asked in the revision for us to comment or really discuss what the MCPs are doing their plans. But that's where I think us working with public health on the chips and chas and things of that sort will allow counties and MCPs to kind of align and match up a little better. Um, I'm not sure how they're doing the plan because they have their large plan, but then I know they have to do plans by like counties, I think. So that'll be something we can try to look into, and I'll check with some of our contacts over there from our work with public health and see if they have that information available or how one would get a copy of that information. Anyone else have questions? Anything in the chats or the social medias? Pluralize those.
Nothing over here.
All right. We still have time, so if there's any questions, you can jot it down. And again, if something pops into your head later, or you really want to kind of think about the question, you can send that to us utilizing the email MHSA Fresno CA FresnoCA.gov or BHSA at FresnoCA.gov. Either one will work. You can ask questions, or even if it's a comment, you can do those as well. You can send those. We ideally prefer those to be like coming through the email because then we can keep a record of it. And we do have to include public comments and questions in our final plan. So there is a section in where we do those, both address them, but also document them in the plan. We'll stay on here for a few more minutes just because we have the time. So if anyone has questions, let us know. Brooke, go ahead.
Sorry, since we are having a public hearing on this, can recommendations in that public hearing from the board, the Behavioral Health Board, that recommendations that would really be for the state, not so much for the county, be included? Or is that something that we would need to send separately to DHCS?
So good question. I don't know the exact answer. So two things. I would say if it's something for the state to definitely, there's probably a couple of outlets to DHCS, but also the Commission for Behavioral Health to say, hey, these are some things that as local behavioral health boards we have a thought or concern. The plan is so set up that like we have to put things in the plan. So that would just go into just a general comment if they review it. There's no specific place in the plan. And at the public comment period, if we're adding a lot of stuff, we potentially risk missing a board date. However, if people submit those beforehand, we can just put it as public comment and put it in the plan. It will go in there, but there's not a specific place other than just a public comment section. So I would say maybe submit those to us beforehand, and we can put those as comments we received, and identify it as members of the board if they have those, and then potentially communicating those to DHCS, the Commission for Behavioral Health, and then I even know there is the California, it's the Association for Teresa Comstock runs that. It's the Association for the local behavioral health boards, and that would be a great way of doing it because they also can probably navigate some way of getting additional feedback to DHCs. But we could put it in a plan, but there's not a specific area other than just in the back comment section. I don't know if that helps. All right.
Nothing on social media.
We're gonna, I think Lisa's typing something, so we'll see if she's gotten any. And again, this is not the end of it. This is just something we have done over the past 7-8 years in Fresno, just what we call our report back session, because a lot of times we do know, as Brooke noted, as you read through it, it is a large document. There's a lot of information. In the past, it was really a way for us to share feedback in terms of what we had heard in the community planning process. So somebody may have pitched some ideas, and they may want to know, like, was my idea taken, or this wasn't in there? And you're like, what about this? And we would in a report back be able to say, hey, we heard that idea. That is actually something we do with the FSPs, and so it's already in there. Or be able to explain, hey, you know what, that falls more out of our purview and is maybe more of a justice thing. So, we will note it, but we aren't necessarily something that we were able to use MHSA dollars for. So it was a way to make sure people got feedback on it to make sure that people knew that we heard them. And it was a way to, again, summarize, sometimes a 600-page document. But with the BHSA, a lot of it is really formatted and structured in a way that doesn't give us a lot of options. So uh, it's less for us to be like, hey, this is what we heard in our community planning process. But it's more of like, hey, this looks different than what you've seen in the past. Here's some of the things to kind of expect or look at. And it may be something of interest, or somebody may want to dive a little deeper into the BHSA plan and review it, or they may go like, you know what, that sounds good enough. I'm not going to read it, but we wanted to be able to give you guys some level of summary for those. So questions, concerns can be directed to, again, MHSA at fresnocountyca.gov. And or the website, you can look for more information. We'll post, like I said, when we put our responses to these revisions that the state has asked for, we will post all of those to the website. And then if you're on a listserv, it'll also go out. And if you want to get on the listserv, just email that MHSA at fresnocountyca.gov. We'll add you to the listserv. So when things go out, you'll also get notified that way, that there's some either updates, there's some new questions, new revisions, what the status is. We will send out a reminder for the, what did I say earlier, May 20th public hearing. That'll be, I don't know if Brooke, if we figured out if it'll be a before or part of, but it'll be on that date tied to the behavioral board hearing. Usually, I know in the past we've done it a little bit before,
Yes,
just so we don't cut into the board's time.
it's before the hearing,
Perfect.
so that there's adequate time. And then we're trying to find out how long the presentation will be so that we can
Perfect.
tell those participants, if they want to come later, they don't want to be part of the hearing,
Gotcha.
about what time to be there.
So we will continue working on that. For those, if the audio didn't pick it up, Brooke did confirm that it will be tied to the behavioral health board meeting on the 20th. It will be before the behavioral health board meeting. We don't have the exact time yet because we want to make sure how long the public hearing would be, both in presentation and time for people to comment or ask questions. And then to understand like how much of that will go into the behavioral health board so that they can let the people know when the behavioral health board meeting will start. So if somebody wants to come just for the behavioral health board meeting, they know what time they get there, so they're not having to sit through the public hearing, or if they want the public hearing to know when to get there. So we have some estimates on that, but some of that right now is contingent on us getting these revisions back to DHCS and seeing kind of like if they have any other comments. But I think we can probably have something pretty soon in terms of a timeline in there. We do try to make sure that we provide enough information in the public hearing for people to understand what is going on, the context, but we don't always get very detailed nuance in there because, we don't want to go through like a couple hundred pages of information for everyone. But we want to be able to provide enough of an overview and support any questions. And if people didn't get a chance to do this and they have questions, we should have this available on our YouTube. It's on our social media. We'll have that there so people can go check it out if they want, just so they can catch up, and maybe this will suffice. And they're like, you know what, that's good enough. I'll just show up for the board meeting, or, you know what, I have some questions. I want to say something. They go, and again, you don't have to wait till the 20th. You can email those comments and suggestions. Thank you, Brooke. Put in here for anyone not on the team's part. The behavioral health board hearing is at 3:30. The behavioral health board regular meeting will be started afterwards, and an estimated time will start up, and we'll go from there with the agenda. So we're trying to work with our local behavioral board to have the information they need so they can set the agenda. And in addition to that being going out on that notice, we will also post that information, more details for the 20th on our BHSA, FresnoBHSA.com website. And if you're on the listserv, you will receive that as well. Usually about 2 weeks beforehand for Brown Act stuff. So we do try to get that out ahead of time, which is coming up pretty soon for us. But any other questions, comments? Thank you guys who joined us taking your lunch hour to do this. We did try to do it at a lunch hour to not take away your lunch, but hopefully not cut into other parts of your day. But if you do have questions, reach out. Like I said, this plan we're writing it, but it is a lot more integrated. So there's a lot more alignment with some of the work our MCPs are doing. I see, Crystal from one of our MCPs on here, who've been working with public health and those CHIPs and CHAs and just a lot more sector. And I understand your point, Brooke, of like it'd be great if they're having this plan to have all those other parts in there. Those of us that are working on the BHC work groups with the state have tried to explain some of those things or you would need folks from the state DSS and local DSS if you're talking about reducing childhood removals, not just a mental health or substance use that triggers those kind of events, and justice involvement. A lot of ways to reduce those. A lot of those fall into the prevention areas. And since the state is doing prevention now, like, hey, we'd love to hear some ways to connect those. But right now, they did put the oneness of the behavioral health integrated plan on us, with us working with our different stakeholders, at least for some of the planning and some input. But yeah, I think there's a lot of opportunities in the future there. If there's no more questions, comments, again, thank you everybody who tuned in. Feel free to share the link information with people. Hold the time. 3:30 is the Behavioral Health Board hearing on for public comment on the 20th. We'll get more details in terms of all the stuff for that. But if you're interested, just save the date, and we hopefully will be talking to you all soon.